These patients were all around the New York City area, and we were examining their experiences with VRI. From that commentary from those patients, we saw the emergence of a number of patterns initially. Many said that the technology was fascinating and they loved the use of technology in some ways, but a number of problems emerged at the same time. Common threads throughout their stories stated that the technology was put in place without any acknowledgement or questioning of the patient on whether or not that was a service they wanted. Patients also expressed difficulty in seeing the technology because of the glitches that were present in the transmission. Also, the doctor, importantly, was standing behind the device, unable to see the screen and unable to see when communication was breaking down. And you may remember we were examining a patient pool that ranged from those quite adept at language. Those that were adept were often embarrassed by their lack of understanding because they expected to have an experience similar to that of a live interpreter, but they came in, sat down, used the technology, and felt ashamed and embarrassed for not understanding what was happening. Many of them were lost to follow up in the study. Now, at the same time, those at the other range of that language spectrum with lower language skills, less adept, their experience was somewhat different. Throughout their lives, they had not been able to communicate well with many others, and so they figured that that was simply their natural state. They never asked doctors questions when technology broke down and communication broke down. They remained passive throughout the experience. A number of problems came forward from that. They were unable to follow the regimen, and they were largely unable to engage with the doctors and healthcare professionals. They were unable to ask questions of those professionals. This resulted in a number of follow-up appointments that were largely unnecessary because of the need for clarification and misunderstandings in prior appointments. So in sum, the result of this project found that patients were largely unable to choose the kind of access they were given, and the access that was provided wasn't effective. This resulted in a lack of autonomy, quite limited, and their engagement with doctors was minimal at best. We showed these films to a number of hospital and medical boards, looking to create better systems and for allowing patients to determine what access technologies would work best for them. And at the beginning of that research, I was quite curious about what medical students were learning in their curriculum about deaf and hard of hearing people. And a number of studies were conducted at the time, and medical students today still don't have, by and large, curriculum explaining the perspectives of deaf and hard of hearing patients. The studies show that patients who were in hospitals are experiencing very common kinds of discrimination regarding their choice of access methodologies. We also see currently an increase in the use of standardized patients for medical student education. The question, though, comes to whether or not these people are accurately portraying a real-to-life experience of engaging with patients with disabilities. And in fact, the National Association of the Deaf compiled a listing of some 25 major concerns related to the use of VRI technology in medical care. We see that we don't have a clear litmus test to show what kinds of access truly provide successful patient outcomes. So what kind of litmus test can we then create to determine what access is best for patient success? I jumped my slide, sorry. Okay. So across the United States, we now have laws such as the Americans with Disabilities Act, which has been profound in its provision of responsibility on the doctor to determine and evaluate effective communication strategies with patients. A number of issues spring forth from this. The first being whether or not doctors have the knowledge base required to properly evaluate this and to engage with the patients on that access. And deaf people themselves having some influence on hospital boards and medical care in determining that kind of access. Patients now have the right to be more engaged in medical school and medical training programs. And in fact, the studies that we've done show that there are some 30 to 40 actively practicing physicians in the United States who are deaf or hard of hearing. And some of the problems regarding the provision of education to deaf medical students and positions of authority in hospital boards and so forth are we have seen that those deaf physicians have not been in those positions to influence these policies. And the deaf students and medical students have largely had to fight for access and by and large had to pay for their own interpreters for accessing that schooling. So this begs the question of the parallels between the deaf medical students' experiences and deaf patient experiences. Deaf medical students are largely denied access to medical schooling, as are deaf patients. The images you see before you are different maps which all could be accessed. Access could be granted into these realms, but whether or not that is truly accessible and navigable for deaf patients is quite another question. Whether it's understandable and navigable is quite important. Minimal access does not equate to patient autonomy. In fact, autonomy has a number of benchmarks that are required. Can the patient engage with and ask questions of their healthcare provider? Can a patient with some education create a more autonomous relationship with their healthcare provider? Are they able to discuss the risks of treatment? These benchmarks could serve as a litmus test for successful provision of access. Patient engagement with doctors, the ability to understand and be educated about the risks of treatment. These are benchmarks that could be used to determine the success of access for any patient. Research has clearly shown that if a patient does have autonomy in their care, this results in more successful treatment with lower costs to hospitals and medical providers. And in fact, I just recently had an experience that I'd like to share with you as a patient. I was going to a new doctor just some 3 weeks ago, going for an annual checkup, emailed them prior to my appointment to let them know that I wasn't requesting VRI nor a live interpreter for that routine visit, that I was happy to engage vocally with them and write back and forth. So the appointment all set, I showed up for my appointment that day, sat in the waiting room for quite some time. In fact, an hour and a half idly waiting the hours away. An hour and a half later, the doctor came in profusely apologizing for the delay, stating that they'd been waiting and searching for an hour and a half to find a computer to provide VRI. But an hour and a half was spent looking for a kind of access that I didn't require and didn't ask for. So these members of the hospital staff and the doctor were not providing treatment to the patients in the waiting room and engaging in unnecessary efforts to try to bring that technology rather than engaging directly with me as a patient to determine what my needs for access were. And so I'd like to go back to this image of these somewhat accessible mazes. They are, in name at least, accessible, but they do not reflect an ideal of patient autonomy and navigability. And so we need to determine what could best provide autonomy for patients for more successful patient care. Thank you very much for the opportunity to speak to you today.